Thank you, Peter. Good afternoon. What I would like to do is to present some important data regarding the epidemiology and management of patients with valvular heart disease, what is the current unmet medical need, and how we can try to make that better. Let's start with basics. What is heart valve disease? Is when disease of one of the four valves, the two on the right, pulmonic, tricuspid, on the left, mitral and aortic. And we have two conditions, two pathology of the valve disease, which is stenosis, when the valve doesn't open well, or regurgitation, when it's not closing well. And the two main diseases are aortic stenosis and mitral regurgitation. And you need to differentiate for mitral regurgitation, primary MR, which is due to structural abnormality of the leaflet or chordae, to secondary MR, where the valve is normal, but it's due to LV remodeling and dysfunction. When you talk about valvular heart disease, main thing is that it's a disease of the elderly. If you look at the change in epidemiology in the past decades, you see that there is a huge, at least in Western countries, huge decrease of rheumatic valve disease. And now we have seeing patients with degenerative valvular heart disease. If you look at the prevalence, has been evaluated in the community at the Mayo Clinic, you can see that the prevalence of valvular heart disease is huge. 4% in patients between 65 and 74, 11% above 75 years old. And we all know that in Western countries, population is aging. You have here the pyramid of age that we are currently facing, what we will face in 40 years. And based on the Statistic Canada, if you look at the prevalence of patients above 60 years old in Canada, it's currently around 7 million, and we expect 12 to 13 million in 2063. So, and if you want to assess the prevalence of disease, you need to do echo, which is the best way to diagnose valvular heart disease. And in Oxval studies, they screen patients above 60 years old from the primary care perspective, use echo to screen for patients with valvular heart disease. And based on this data, the projection is that in the UK, the number of patients with valvular heart disease above 60 years old will double from 1.3 million in 2015 to 3.3 million in 2056. Swedish and all the northern countries are very good in Europe because they have large registries of everything. Here you can capture all the population of Sweden, almost 10 million of patients. And you can see again, huge increase of valvular heart disease with aging. The most common is aortic stenosis, and the second one is mitral regurgitation. Tricuspid regurgitation is the same, a new entity that is more and more recognized. You can see that the prevalence is high, and the prevalence of tricuspid regurgitation is as high as aortic stenosis in the population now. So it's clear that valvular heart disease is the next epidemic we are going to face. It's not because it's degenerative, it means that it's passive. There is a pathophysiology underlying the disease, it's a progressive disease and active phenomenon. For AS, there is better and better understanding of the pathophysiology, implying lipids, oxidation, cell differentiation, and production of calcium. For mitral regurgitation, we have identified some genes that are responsible of the mitral valve dystrophy or mitral valve prolapse. But despite this progress, what is very important to understand for valvular heart disease, there is no medication that can stop or prevent the progression of valvular heart disease, and the only treatment is some kind of intervention. Most of the time, it's surgery. And if you don't do that, patients do not do great. If in patients with aortic stenosis that were contraindicated for surgery, in 2010, they were randomized between TAVR, so transcatheter aortic valve replacement, and conservative management, which meant nothing. And you can see that if you do nothing, the rate of death at 2 years is almost 80%. If you do an intervention, you improve markedly the prognosis of patients with valvular heart disease. So to summarize that, valvular heart disease are lethal disease. If you don't do anything, the patient is going to die, and we don't have any medication now to prevent the progression of the disease. But there is hope. We have new intervention. With transcatheter therapies, we are able to fix mitral valve, aortic valve, and now also tricuspid valve. And has a huge impact on the management of this patient. We have collected data from France. All aortic valve replacement performed in France from 2007 to 2015, and you can see that there was a huge increase of the total number of aortic valve replacement performed in France. This increase was not due to the increase in prevalence of the disease. Prevalence of AS remained the same during that time, but it was due to the increase of the number of transcatheter valve therapy that has been performed. And it was mainly in the elderly patient at that time. This means that elderly patients that had aortic stenosis were left intubated at that time, and after the introduction of transcatheter valve therapy, we are able to provide them now a treatment to cure the disease. So transcatheter therapy has completely changed the management of patients with valvular heart disease. If you want to manage a patient with valvular heart disease, there is 3 important conditions. First, you need to know that the patient had the valvular heart disease. After that, you need to follow carefully the patient. And as a good timing, you need to send the patient for an intervention. Are we doing good in clinical practice? I will show you some data showing that we are not doing so great. This is a survey done in people, so not only patients, but people above 60 years old, and they were asking about aortic stenosis and conditions regarding valvular heart disease. And you can see here that most of the patients do not know what is a valvular heart disease. They know what is Alzheimer's disease, they know what is stroke, they know what is heart attack, but valvular heart disease, they don't know what is that. And what is even more scaring is that when they go to the family doctor, most of the time they don't get a clinical auscultation. So if you don't auscultate the patient, you cannot find if the patient has a valvular heart disease. This was from the patient perspective. If you now ask physicians what they are doing. It was a survey performed in Europe, more than 500 physicians, family doctor, cardiologist, subspecialty cardiologist, and even surgeon. And they asked, based on clinical scenarios, what was the knowledge and clinical practice. And you can see again from the medical perspective that most of the time physicians do not auscultate patients. And it's very important. If you want to screen a patient efficiently, you need to auscultate, but one way to do that is also echocardiography. And you can see from the Oxval study I've presented earlier that 50% of patients had valvular heart disease that was undiagnosed before that. In green, it's a mild valvular disease, but you can see in brown that a significant number of patients with moderate to severe valvular heart disease were not diagnosed before these patients were screened. So clearly, valvular heart disease are underdiagnosed. When they are diagnosed, what is the management of this patient? It was a study done at the Mayo Clinic. They look at patients that had an echo done at Mayo Clinic with a clear diagnosis of moderate to severe mitral regurgitation, and the report was sent to the physician. And they were evaluating what the physician has done with the report. First, you can see that we recognize again the increase of valvular heart disease is here mitral regurgitation with age, that this patient had an excess mortality compared to what was expected for the same age and gender. It was true overall, but also with patients with a normal ejection fraction. But the main finding of this study is that despite a class 1 indication for surgery, a clear indication for surgery, only 20% of patients with mitral regurgitation, moderate to severe, at the Mayo Clinic did not underwent any mitral valve surgery. It was not an issue regarding social security or insurance. It was not an issue regarding the quality of the care that can be provided, and by Mayo Clinic, they have access to all mitral regurgitation treatments. We look at that also in France. We were able to capture all patients that have been admitted in French hospital in 2014 and 15 with a diagnosis of mitral regurgitation. You can see again that only a minority of patients with mitral regurgitation had surgery. Only 8% underwent surgery within 1 year. Most of the patients, 92%, were conservatively managed, and 2/3 were primary, so organic mitral regurgitation. 1/3 was secondary. You can see again that we are dealing with an elderly population. Mean age was 77. 50% have more than 80 years old, 12% more than 92. And huge comorbidity, more than 50% of the population had a Charlson score of more than 2. In terms of outcome, was not great. 1-year mortality was 14%. 2/3 of the patients were either dead or readmitted at 1 year, and 1/3 dead or readmitted for heart failure at 1 year. And it was true not only for secondary MR, but also for primary MR. And if you look at the cost, huge impact on the community. If you add first admission plus readmission, that were very common, the total burden is estimated between 300 million to 500 million euro per year. And this has an impact on the clinical presentation. We look at this registry. We were able to collect more than 2,000 patients with severe aortic stenosis across Europe. 23 centers were participating. This paper has been just published last year. And the main finding were that, again, main patients were elderly, that they were frail, had significant comorbidities. They were still referred very late in the course of the disease, had severe symptoms and LV dysfunction. And despite the fact that we have now the capability to doing transcatheter aortic valve implantation, only more than 20% were denied any kind of intervention. Let's skip that one. So clearly, valvular heart disease are undertreated, and patients are still referred late in the course of the disease. One potential explanation has been evaluated in this survey. So when they ask physicians, you can see that many physicians are not aware of when to intervene, how to evaluate, what's the difference between threshold from primary and secondary hematologic regurgitation. So there's clearly an insufficient knowledge of the physician regarding valvular heart disease. And when the patient is, so you have the diagnosis and you have decided to do something, what are the results of what you are doing? We look at the mitral valve surgery performed in France, so we were able to collect 18,000 of patients that had mitral valve surgery from 2014 to 2016. You can see here that 40% had degenerative mitral regurgitation, 16% secondary, and 40% had either rheumatic disease, endocarditis, congenital, or could not be classified. In hospital mortality, mitral valve surgery in France was 6%. In hospital, 1 year mortality or readmission was 13% for degenerative and 27% for secondary MR. And you can see that the prognosis was worse when it was a replacement compared to repair, and when the surgery was combined compared to isolated. Another important result of the study was to evaluate the rate of repair. For mitral valve, degenerative mitral disease, repair is the best treatment for patients. And you can see that overall in France, where the technique of repair was invented, the rate overall repair from patients with degenerative mitral regurgitation is around 70%, the same than in the US. Even in the best subset, patients below 60 years with no comorbidity, the rate was only 84. And two subsets where had a worse, less chance to have a mitral valve repair were women with a significant difference, whatever the age, whatever the comorbidities, and elderly patients. Less repair that performed in women and elderly people. So there is clearly an inequality in the treatment that is provided according to centers in patients with valvular heart disease. So what can we do? What's first thing we can do is to raise awareness in the population, among physicians, about about the importance of valvular heart disease. If you compare, so in the population, the study we have done in patients with mitral regurgitation, we have 50,000 new patients admitted with MR every year, the same as breast cancer. Rate of death is the same for MR than breast cancer. We need to improve screening. Physicians do not auscultate patients, but we can help them if we use some kind of artificial intelligence like computer-aided auscultation. We are currently evaluating one of these systems. So every patient referred to the echo lab has a recording of heart sounds. We will evaluate the accuracy of this technique compared to echo as a reference. We have already included 400 patients. You can use point-of-care echo. The best way to diagnose valvular heart disease is to use echocardiography. Auscultation is great, but sensitivity and specificity is not perfect. With echo, we have a high-quality method to diagnose patients with valvular heart disease. And we have now a very small device that can be used at bedside and to diagnose echo. The main problem with the point-of-care echo is that you need people that are trained to do the acquisition of the pictures and are able to do the interpretation, which is not very common. In parallel, we have evolution in the technology. Now, with this new technology, we are able to share the screen of the patient scanning another part of the world. The patient is in Africa, we can be in our office and look at what they are doing. And our idea is to combine both techniques, the point-of-care echo and the live remote support. We can provide GP with the new ear Philips system to scan patients, and remotely we can help them to do the good requisition and to do the interpretation of the images they are getting. We can offer also the murmur clinic. We have advertised that to GP in Ottawa, that any patient diagnosed with murmur can have a rapid access to the echo lab to diagnose valvular heart disease. This is for the screening part. Now you need to monitor the patient, to follow the patient. And there is more and more evidence that we need to have people that are specialized in the evaluation and management of valvular heart disease to provide the better care. We have, with the help of Dr. Messana and the Heart Institute, we have developed now what we call the Center of Valvular Heart Disease. It's a clinic where we can provide evaluation and management of patients with valvular heart disease. We can perform tests and clinical evaluation the same day. On top of that, we are taking the opportunity of the patient coming to the CVHD to perform research. Every patient is asked to be biobanked and to be entered into a prospective database. And it will provide us cohort. It's very important to have administrative database, to have large registries, but we need also prospective cohort, very well phenotyped, to get different kind of data. We are doing currently that for aortic stenosis. We are going to start that for patients with mitral valve disease, with the help of this patient that has just been published in the International Journal of Cardiology, showing that patients with mitral valve calcification and mitral valve disease are often symptomatic and denied any treatment. So we need to better understand what is the pathophysiology underlying this MAC to prevent the progression. Cohorts are very helpful in the management of patients, to improve the management of patients with valvular heart disease, like patients with aortic stenosis. There is, in 1/3 of the patient, discrepancy between the mean gradient and the valve area in patients with aortic stenosis. Most of the interest has been focused on patients with low gradient and low valve area, but nobody has looked at patients with high gradient, high valve area. And we have looked at that in our cohort. This paper has just been accepted in JACC Imaging, showing that patients with high gradient and high valve area behave exactly the same than patients with high gradient, low valve area. So I think we can change this smile for now, a nice smile. And we can intervene. We have looked at that in the input registry. The main aim at the beginning was to, when the patient had an echo, 1 week after, to contact the family doctor or the cardiologist and to tell him that your patient had severe ES. These are the recommendations for intervention. You're aware of that, and you can maybe change the management of this patient. It has been just published in JHA. We're not very successful in terms of impact. We just have, in terms of a number of patients that were referred for intervention, the rate was the same, but we have a little bit of success decreasing the time between identification of the disease and referral for intervention. And when we're thinking about doing something to a patient, it's very important to send him to the center when you can do everything and everything well. This has been called the Heart Valve Center of Excellence. It's high-volume centers that are capable to provide all type of intervention and with excellent outcome. This is the clinical part, and we need to integrate both clinical research, clinical care to basic research to provide translational research in order to, in the future, to develop medication that will help stop progression of the disease and avoid the need for any intervention. So in summary, valvular heart disease in the next epidemics is touch patients that are elderly with common comorbidities and clearly a suboptimal management. Patients are underdiagnosed, undertreated, sent late in the course of the disease, and there is a clear inequality of the quality of care that is provided. So there is an urgent need to improve the overall management of this patient and to also improve our understanding of the pathophysiology of valvular heart disease in order to develop medication to prevent the progression or to stop the progression. And I thank you for your attention.
When I saw the title, I didn't think